I'm K.D. Weeks, Editor-in-Chief of the Cardiosource Clinical Community on Sleep Apnea and Cardiovascular Disease. It's my pleasure today to introduce to you Sean Caples, Assistant Professor of Medicine at Mayo Clinic. Sean, welcome. We're glad to have you on the show and appreciate your help. I want to start by saying that cardiologists and practitioners spend a lot of their time taking care of patients with atrial fibrillation. It almost seems as if there's a major surge in the number of patients out there with atrial fib. What is the scope of the problem as it intersects with sleep-disordered breathing and atrial fib?
Well, thanks for having me, KD. It's good to be here. It's not surprising that cardiologists are seeing more and more patients who have both atrial fibrillation and sleep-disordered breathing. It's been high on the radar recently amongst sleep specialists, cardiologists, pulmonologists, internists. It seems to be a big problem, although epidemiologic evidence has been limited mostly to referral populations. So if you look at the literature, there are high prevalence rates of patients who are presenting to sleep clinics or to cardiology clinics who happen to have both atrial fibrillation and who have obstructive or central sleep apnea. Some of our data has shown prevalence rates as high as 60 or 70% in patients who are referred for atrial fibrillation who then turn out to have sleep-disordered breathing.
Is there a causal relationship, and if so, what are the mechanisms?
Well, that's a good question. So far, the literature hasn't borne out a causal relationship. There's a strong association, a tight link between the two disorders. They often coexist in a population of patients with cardiovascular disease and sleep apnea. The causal mechanisms are some of the similar ones that we implicate in sleep apnea. There are repetitive surges of hypoxemia that stimulate the chemoreceptors, leading to autonomic dysregulation, surges in sympathetic tone, even surges in vagal tone, which may be important in atrial dysrhythmias. In addition, patients with obstructive apnea who have upper airway obstruction generate tremendous negative intrathoracic pressure as the upper airway collapses. Pressures that can exceed minus 60 centimeters of water. And it's felt that perhaps these negative pressure swings can affect the thin-walled atria, can cause remodeling or maybe even fibrosis in the atria. Sleep disruption in and of itself can lead to a state of enhanced inflammation. Patients who have both AFib and sleep apnea tend to have elevated levels of C-reactive protein, so this may be operative as well.
We know there are treatments for sleep apnea, but do the effects of treatment have an impact on the outcomes of treating atrial fib?
Yeah, that's a good question. There are no prospective trials to assess the impact of treatment of sleep apnea on atrial fibrillation. There are a number of retrospective case series looking at outcomes of atrial fibrillation. I think we have to back up a little bit and talk about the two separate entities of sleep apnea. There's obstructive sleep apnea associated with upper airway collapse, which really is a straightforward type of treatment with a CPAP machine. On the other hand, there's also an association between atrial fibrillation and central sleep apnea. CSA is, we don't know as much about CSA and its outcomes as we do in the OSA population. The treatment of CSA is varied. It may be something as simple as optimization of cardiac status. For example, a patient with heart failure who also has atrial fibrillation, if you medically optimize these patients, central sleep apnea tends to get better. In the absence of heart failure symptoms, we then look at devices such as the adaptive servo ventilator or the ASV machine, which is a relatively new player on the block. It's been the past few years that we've used these ASV machines to treat CSA. So if you look at the obstructive apnea patient, there are some retrospective reviews of those who have undergone treatment for OSA and have had their atrial fibrillation monitored. It seems that the preponderance of the evidence is that treatment with a CPAP machine for OSA might lead to an interruption of the natural history of atrial fibrillation. That is, AFib may be positively impacted by CPAP treatment in OSA patients. We've also looked at patients who have undergone cardioversion as a treatment for their atrial fibrillation. In that population, if they have sleep apnea and they adhere to a CPAP regimen, their risk of the recurrence of atrial fibrillation in the succeeding 1 year is reduced by almost 40% compared to those patients who are not treated for sleep apnea. Again, that's a retrospective study. There's a lot of biases built into that. Those kinds of findings need to be replicated in prospective studies. There are some that are being undertaken as we speak. For the CSA population, not as clear. There are really very little data in this domain. There are large heart failure trials that are now underway using ASV machines. There may be some sub-analysis of heart failure patients with AFib who are being treated with this therapy, and it remains to be seen whether there are positive outcomes associated with that treatment.
So in summary, your recommendations for the practicing cardiologist in terms of identifying and managing and treating patients with coexistent sleep apnea and atrial fibrillation, what would they be?
Yeah, that's a really good question. I think we have a strong referral base here at Mayo. Most of the cardiologists are in tune with the issue. We get a lot of referrals for a sleep evaluation in many patients who have AFib. I have to say that the specificity and sensitivity of automatic referrals in the setting of AFib probably is pretty low. I think it would be helpful for the practicing cardiologist to ask simple questions about their patient's sleep, and in addition obtain collateral history from the bed partner, the wife or the husband. Tell me about your snoring. Tell me about whether you observe your spouse pausing and breathing. Tell us about the quality of your sleep. Do you wake up feeling refreshed? Do you wake up feeling tired? Are you sleepy during the day? I think these are a few of the salient questions that can be asked in the office in the matter of a minute or two. And if there's evidence that sleep is disrupted, that there may be pauses in breathing that are observed by a bed partner, those are strong predictors of sleep apnea and also strong predictors of responding to treatment with a CPAP machine.
Well, this is excellent. Thank you very much for sharing your insights and your vast experience in treating both patients with atrial fib and sleep apnea.
Thanks, Katie.
Thank you, Sean.